everyone. Thanks for joining us for this Part B Osteopathic Manipulative Medicine Common Rejections and Denials webinar. This webinar is designed for those who submit claims on a CMS 1500 claim form or the 837P electronic claim. My name is Mary Mucko. I'm a specialist on the Provider Outreach and Education team at WPS GHA. I will be your speaker today, and assisting me is my friend and colleague, Leanne Foster. We begin this event with this disclaimer that we include in all our education, and we do so to remind learners that although we made every effort to provide current information that is correct, the information is subject to change, and it is on the CMS website where you will find Medicare rules that determine Medicare final coverage. These laws, regulations, and rulings will always prevail. We will provide responses to questions based on the facts given. And finally, CMS prohibits recording of this presentation for profit-making purposes. We are recording this webinar and we will post it as an encore presentation. You can stay informed about new postings of the latest encore presentations and other education events by reading the education news that we post each week on Wednesday. This is the copyright notice that we provide for the American Medical Association. Your continued participation in this webinar infers that you agree to the terms of this copyright notice. Should you not agree to acknowledge this copyright notice, you may disconnect from this webinar. Here is our agenda for today. Just as we advertised in our announcements for today's webinar, this webinar and the content of it really focuses on data. And the data comes from 1500 claim form or 837P electric claim submissions for only specialty type 12 providers. Specialty type 12 is osteopathic manipulative medicine. I'm going to provide details during this webinar on the common rejections and denials for specialty type 12. I'll give you some information on how to fix and avoid both common rejections and denials, and I'll provide you with many resources. And then if there's time, we'll take live questions, or I'll provide a resource for you that you can submit any questions for a period of 7 days following this event. Now, to fully understand rejections and denials, it is important to recognize the path that a claim takes, or what we sometimes call the life of a claim. Here's a simplified graphic on how a claim gets into our system. The provider or supplier will render a service, submit the claim, but the system might reject that claim or claims. And when this occurs, we generate and send a 277 or 999 report. This slide describes claim submission in a little bit more detail. Now, most providers do submit claims electronically. There's actually very few providers and suppliers who qualify for a waiver under a law that prohibits Medicare from making payment on a claim that is not submitted electronically. So to confirm claim receipt, providers or suppliers should use the 999 report. Providers use the 277 report for more specific information. Now, our electronic data interchange, or EDI staff, has created the Medicare 276-277 companion guide. You can see here that I have linked to that guide on this slide, so in the electronic copy that you've downloaded, you'll easily be able to get to that resource. This guide helps clarify and it helps further define the data content requirements for an electronic claim. Now, based on both of these reports, you will know if the claim is rejected or if you need to correct or resubmit the claim or the batch. This is a simplified graphic that shows what happens to a claim that Medicare deems as unprocessable. We call those rejected claims. And it's really very important for you to recognize that there is a huge difference between a rejected claim and a denied claim. Sometimes we use those terms interchangeably. I know I catch myself at it every now and then, but they really are very different, and we need to make certain that everyone understands that. This slide then shows a side-by-side comparison of a claim rejection and a claim denial. Now let's talk about rejections first. Rejections are called unprocessable. They are returned on the front end because they are never actually adjudicated. These are rejected because something's invalid, it's missing, or maybe incorrect information that causes this rejection. And because that claim is rejected and not adjudicated, there are no appeal rights. So what you need to do is resubmit the service. Now, when you receive the remittance advice for a rejected claim, you will see on that remittance advice, or sometimes we call it the RA, an MA 130 and CO16 code. The MA130 is a remittance advice remark code, and basically what that tells you is that the claim includes incomplete or invalid information. There's no appeal rights because that claim is unprocessable. What you need to do is submit a new claim with the complete or correct information. Now, the CO16 is a group code that appears on the remittance advice, and the CO16 means that it's a contractual obligation, and that means you can't bill the patient for those services. You need to resubmit that claim. I'll be talking a little bit more about reason and remark codes a bit later. A denied claim, on the other hand, is adjudicated, and the service may be denied. It could be the entire claim denied. It could be a claim line denied because it fails to meet payment criteria. And what we're talking about here could be a number of reasons. It could be due to a law or what we call a statutory requirement. The service may be denied as not medically necessary. Not medically necessary denials include those kinds of services that have a frequency or utilization parameter. All of those are considered medical necessity denials. Or perhaps that denial could be due to eligibility. It could be eligibility on the part of the beneficiary or your patient, or it could be an eligibility denial that pertains to the provider of the service. At any rate, when a claim is denied, in most cases, there are few exceptions, there will be an MA01 code on the remittance advice, not on the claim, that provides appeal rights, tells you you have the right to an appeal, and provides further instructions for requesting appeal. Now, for denied claims, the patient liability will be determined. Here then is a graphic that shows the path for a process claim. The service is provided, the claim submitted. Medicare will either pay the claim or deny the claim and send out that remittance advice. Let's talk about that remittance advice just a little bit here. Sometimes people call it the remittance notice. Some people may shorten that up and call it the remit. Other times you'll hear people call it the RA. Most providers receive an electronic remittance advice, or ERA, as opposed to a standard paper remittance, or SPR. Now that ERA is going to provide details about the transfer of funds and payment processing from the payer to the healthcare provider's bank, and depending on how the claim processed, it might also include information about any adjustments made to the claim or denials. It could also include information about something that's missing. Sometimes it even provides notice about refunds and offset. There are codes on the remittance advice, I talked about a few of them a bit earlier, that provide information about the claim. Now, claim adjustment reason codes, or CARCs, explain why that claim paid differently than it was billed. Remittance advice remark codes, or RARCs, provide more details about that adjustment that's described by the CARC. Another type of code, and one that I just talked about a bit ago also, is a group code. These convey the financial responsibility for any unpaid portion of a claim balance. As I mentioned earlier, that CO is contractual obligation. It means the provider's liable. You may not bill the patient. A PR group code on the remittance advice would mean that the patient is responsible for that unpaid balance on the claim, for that denied service. You can find code lists for reason or remark codes and group codes on the Washington Publishing Company's website. This is the contractor that maintains those codes for CMS. The code lists, as I mentioned, are on the website. Sometimes we get comments or questions or inquiries that come to us asking us to change one of those reason codes that print out on the remittance advice, but WPS is unable to do that because it is the Washington Publishing Company that maintains those codes. The website that I've linked to here on this particular slide will link you to a page that includes information about how you can contact the WPC if you wish to do so. Now, we do understand that some of those codes may be cryptic or may even seem to be out of date or are out of date. For example, some of the code messages that print out on the RA or on the remit may include an outdated acronym. Now, after reviewing that remittance advice, you will need to choose the action that you need to take. You'll need to fix, correct, resubmit, or request an appeal. So for an unprocessable or a rejected claim, you'll need to fix the error and resubmit the claim to Medicare. Now, if the claim denied or a claim line denied, there may be multiple actions to choose from. You may be able to simply resubmit the service. Excuse me. You might also use the clerical error reopening or CER process, CER, CER process to correct clerical errors. And CMS defines clerical errors, including minor errors or omissions, as human or mechanical errors on the part of the party or the contractor. I'll talk more about that CER process later in this webinar. Another action to consider, of course, would be an appeal. The remittance advice will provide appeal rights, and as I mentioned, in most situations, with very few exceptions, there are appeal rights when a service denies. I'll discuss appeals a bit later in this webinar. Now, registered users of our transactional portal, that's the secure side of the WPS-GHA website, may be able to render a clerical error reopening or request an appeal depending on, what happened to that claim. Did it reject or did it deny? And this of course is just one of multiple self-service tools that we offer. And keep in mind that those self-service tools are there for your use because they really do offer the most efficiencies. Our portal manual provides illustrations and step-by-step instructions on how to use those self-service portal features. Here are just a couple of CMS resources about the remittance advice if you'd like more information about it. So I've included these here, and again, these are embedded links in that electronic handout that you were able to download. Next, I want to talk about when you need to correct or appeal the MAC's decision to pay or deny a claim. And for those of you that are not familiar with the acronym MAC, M-A-C, it stands for Medicare Administrative Contractor. WPS-GHA is the Medicare Administrative Contractor for Jurisdiction 5 and Jurisdiction 8 providers. That's Iowa, Kansas, Nebraska, Missouri, Indiana, and Michigan, Part A and B providers and suppliers. I talked earlier about the clerical error reopening or CER process, And I told you that I would share more details later in this webinar. Now, this is the process to correct those human or mechanical errors. Clerical errors or minor errors are limited to errors in form and content. They are not omissions such as failing to bill for certain items or services. Now, your handout includes the link to the resource titled How to Request a Clerical Error Reopening. Examples of acceptable clerical error submissions are included on that particular resource on our website. Include such things as a mathematical or computational mistake, perhaps a transposed procedure or a diagnosis code. Maybe there was simply inaccurate data entry, misapplication of a fee schedule, or computer errors. And there's also on that resource available on our website um, examples of situations that cannot be processed as a clerical error reopening. Some of those kind of examples, or some of those examples rather, are comprehensive error rate testing or CERT issues, provider enrollment issues, wrong payee situations. There's also several complex claim situations that cannot be rendered as a clerical error reopening. This would include any claim with a not otherwise classified code or claims with certain modifiers. 22, for example, is one of those modifiers for which a clerical error reopening cannot be rendered. There's also you also may not use this particular process for any claims that require the analysis of documentation. And remember, you can use the portal for self-service or request a SIR via telephone or fax if you're not using the self-service feature rather. That portal user manual that I mentioned earlier does provide you with those illustrations for this functionality. I want to talk a little bit about appeals, and I could go on for 60 minutes alone just on this topic, but it's important for you to know that there are 5 levels of appeal if your claim denies rather. There are time limits for submitting and for completing an appeal, and there's also monetary thresholds for filing that vary for some of the levels of an appeal. Those monetary thresholds are referred to as the amount in controversy, or the AIC, and an amount in controversy in the Medicare appeals process appeals only to levels 3 and levels 5, and based on law, these monetary amounts could change from year to year. They don't always change, but they can change from year to year. You can check out how to appeal a claim determination on our website. It is a resource, and I believe it's listed perhaps on the next slide for you. Yes, it is. That particular resource provides information to you about the 5 levels of appeal. It also includes details about who can request an appeal. So the beneficiary or their representative may request an appeal on any service that's processed for them. However, providers and suppliers can appeal services for which they accepted assignment. There's some exceptions though. For unassigned claims, providers and suppliers can act as the beneficiary's representative, but only if the beneficiary signs an authorization statement. And one example of this is the CMS 1696 Appointment of Representative form. Providers and suppliers can also request a redetermination, that's the level 1 appeal, on an unassigned claim if Medicare denied the service is not medically reasonable and necessary, or when the provider or supplier billed in excess of the limiting charge. And in such a case, the provider or supplier must refund any fees that were collected from the beneficiary. And remember, we recommend using the self-service options for more efficiencies. Obviously, you're not able to render the appeal, but the self-service options we have available are the option on these the portal, the secure portal on our website, allows you to request an appeal. Now, here are those additional resources for appeals. That first one is the one I mentioned, how to appeal a claim determination. It provides for you a little bit of information about using the self-service option. It also gives you addresses and fax numbers if you wish to submit the appeal request that way. Now, the second resource here on this particular slide is one of my personal favorites, so I do like to share it with folks when I'm delivering education to learners, and that is the CMS Fee-for-Service Appeals Process Flowchart. This appeals process flowchart includes both the standard and expedited processes for appeals. The standard process is for parts A and B, and the expedited process applies for some Part A only appeals. So I do want to mention that to you. It is updated annually. So if it's the beginning of a new year and you're using this flowchart, you're going to want to make certain that you're going out to the CMS website and using the one that is valid for the particular date of service that you're submitting or requesting the appeal for. Because those, for example, those amounts in controversy can change from year to year, and that would be at the beginning of a calendar year. That flow chart is an easy to view graphic that shows you all 5 levels of appeal and those time frames and those dollar amounts. So it's just one of my favorites that I like to share with you. All right, at this time, or during this next portion of this presentation today, I am going to include a discussion of the data that I used to provide the most common rejections and denials for Specialty 12, Osteopathic Manipulative Medicine. Now, I did go to a tool that was designed by our data staff for provider outreach and education use. It is a tool that we can very, very quickly, just in a matter of seconds, almost instantaneous, apply certain filters to view common rejections or the top rejections and top denials, and we can actually break down that data too. I'll talk about that a little bit more later. But the data that I'm sharing today, and it is specific because I pulled it only for Specialty 12 submitted claims for Jurisdiction 5 and Jurisdiction 8. So that means the states of Iowa, Kansas, Nebraska, Missouri, Indiana, and Michigan. Now, while the dashboard allows us to drill down by a specific state or states or even counties, I pull data for our entire jurisdiction. Now, so again, for those of you who are wondering what Specialty 12 is that I continue to talk about, it is a code assigned to WPS GHA providers when they enroll. During the enrollment process, providers self-designate a primary specialty. Now, while a provider can designate a secondary specialty or other specialties, it is only that primary specialty, the one designated, that is used during initial claim processing. There are some situations where a provider will request an appeal and stipulate their secondary specialty in order for Medicare to make payment. That's done on an appeal level or during the appeal process. But Specialty Code 12 is Osteopathic Manipulative Medicine, and I pulled data for claim submission dates February 1 of 2024 through March 30 of 2024. The data that I looked at and pulled for inclusion in this PowerPoint presentation was last refreshed on May 7 of 2024. And what that means is that any claims submitted by Specialty 12 providers to WPS for this date range after May 7 of 2024 are not included in the data that I will present. Okay. So let's take a look at those common rejections. I've listed them by reason, and I've done so because these reasons, when we look at this data dashboard that folks in my unit have access to, this is the reason that prints out on that remittance advice. CMS, in their internet-only manual, specifically states and instructs to the max that we in provider outreach and education must provide education on these top rejections and denials in order for providers to be able to correct them, resubmit them, fix them, avoid them, and such. And we can actually look at trending to see if our education is helping. The most common reason for rejection for specialty 12 providers for the dates of service that I looked at was that the claim lacks information that's needed for adjudication. You see 98 there. 98 is the number of rejections during that time period for this particular specialty code. Now, claim lacks information needed for adjudication is one of those reason codes that processes or publishes or posts rather on the remittance advice, and you're going to want to dig a little bit deeper for more information. Typically there will be another type of reason code in addition to this one on the claim to help you know what it is you need to fix and resubmit. This is a rejection. Remember, there's no appeal rights for rejected claims. You need to fix it, resubmit it. Claim lacks information needed for adjudication. Look at the items on the claim form or the electronic equivalents and make certain that all of those items that are required elements of a claim are complete and filled out. There are certain situations when the item or the information on a claim is situational and you don't need to fill that particular item out on the claim or that place that data on a claim unless there are certain conditions that exist. Another common rejection is missing, incomplete, and invalid ordering primary identifier. Medicare does require for most services the ordering provider on a claim form. If it's missing or incomplete or invalid, Medicare is going to reject that for claims, or 19 claims. I got ahead of myself here. I apologize. 19 claims rejected. Next, common rejection reason, 15 of them is invalid or missing modifier. Did you neglect to put the modifier on the claim when it was needed? Is it an invalid modifier? Did you use a modifier that doesn't go with a particular CPT code or HCPCS code? These are the kind of things that you would need to check to avoid this. I mentioned earlier to you that sometimes these reason codes that print out on the remittance advice are a little cryptic or just seem a bit off. This is a great example of that. Look at that first word there. It says denied, invalid or missing modifier. It's not a denied service. It's a rejected service. So this is just one of those quirky reason codes that if I, in a perfect world, it would include that word denied because there is no denial at all. It is a rejection. You need to fix it, resubmit it. We have modifier fact sheets available on our website for most of each modifier. You can go to those fact sheets, look at a particular modifier that you used on a claim or you want to use on a claim. You can see examples of appropriate use. You can see examples of inappropriate use. Sometimes we even give you a CPT or HCPCS code range that is valid for that particular modifier. So those are just some ways that you can fix or avoid that particular rejection reason. The next one is that the diagnosis is missing or not linked. Don't bill the patient. You need to submit a new claim. So you'll need to link up the diagnosis to the particular service or add it if it was missing. When we're talking about diagnosis codes, we're talking about the ICD-10 codes here, folks, and linking them on the claim form in the appropriate place. And the CMS 1500 claim form instructions that are published in the internet only manual will actually provide the information that you need to know how to link that particular diagnosis code to a particular service. And I'm going to point those out to you in a little bit when I go over one of just many, many resources that I've provided in your presentation materials. The next one is a rejection because the place of service conflicts with the procedure code. You need to submit a new claim. Sometimes there are certain procedures that are not allowed in certain places of service. One way to avoid this type of rejection is to, number one, double check to make sure that you're billing the correct two-digit place of service, and there's a place of service code list on our website. I've included it it in your resources. But another thing that you can do if you can't find the answer to your question elsewhere is to pick up the phone and call customer service. But you need to be careful when you ask them a question. What you'll need to say to them for this type to avoid this type of rejection is, will your system accept this procedure code with this place of service? What you can't do is give them a scenario or explain, our patient came in to the office and this is what we did. Can we bill this in the office? That is a type of coding advice type question. And we are prohibited from offering coding advice. So you need to keep away from those situations or scenarios and simply say, will your system, meaning the claims processing system, will your system accept this procedure code in this place of service? All right. The next commonly rejected reason is field 11 of the HCFA 1500 must be completed. Notice that first word there, and on the next next example too is denied. It's not a denial, it's a rejection. And also this first one includes HCFA. HCFA stood for healthcare, or still does, Healthcare Financing Administration, but we no longer refer to the claim form as the HCFA 1500, it's the CMS 1500. CMS, of course, stands for Centers for Medicare and Medicaid Services. So there, folks, is just one situation of one of those reasons that seems a bit outdated. Field 11 is that field on a claim form, the paper claim form that is there, where you have to tell Medicare if there is another insurer that could be primary to Medicare or that is primary to Medicare. If the answer is no, you can't just leave that field empty. You have to put none there or your claim will reject. And that's what typically happens here. There is none. People don't fill it in then because there is none. But because they didn't put the word none in that field, that claim line rejected. Next, denied, rendering physician number invalid or missing, submit new claim. Here, folks, is where you will need to check the ID for the rendering physician on the claim. Was it valid or was it missing altogether? And fix it and resubmit it. Next up, not covered, payment already made for same or similar service. This could be a situation where you've already received payment for that service, or you have already received payment for a similar service. So you're going to want to look at the service that was billed and check to make certain you billed it correctly. Was there a local coverage determination that determines coverage parameters for that item or service? Check your records to see if you've already received payment for that service. If you have already received payment for the service, of course, this would be a situation where you wouldn't fix it, resubmit it, because you've already received payment. The next one is claims should be sent to United Mine Workers of America for processing. This is a form of Medicare secondary payer situation where the claim needs to be sent first to another payer for processing before Medicare will consider payment on a secondary payment basis. This is an eligibility type or a Medicare secondary payer type rejection. We do have a lot of great resources. I'll point those out to you as I get to them during the resource portion of the presentation. Next is patient insured HICN. We don't use that acronym anymore, HICN. It is now the Medicare Beneficiary Identifier, the MBI, and the name do not match. The way to avoid this is to have your front office staff checking those Medicare cards when the patients present for services. Make certain that name on the Medicare card identically matches the information that's being entered on the claim form. If there's a middle initial on that Medicare card that the beneficiary holds or presents, it needs to be on the claim. So here then I thought it would be interesting and not just identifying for you or revealing those common rejections by reason codes, but by also sharing with you those commonly rejected codes for those situations I just talked about. So these are the common codes then that rejected for those codes that I just went over individually. You'll see some OMT, osteopathic manipulative therapy codes on here, as well as some E&M codes. We've got the The G0439 also showing up there, which is, of course, that annual wellness exam, the subsequent visit, as well as other codes there. One of the things that you can consider doing when you're filling out that brief survey that we ask you to complete later on today, I'll tell you how you can do that, is if you want a further breakdown of some of these codes, we can do that. We just didn't advertise we were going to break down by code for this event, but if it's something that you think might be helpful for future events, keep that in mind when you're filling out that survey. All right, now we talked about rejections. Let's get to the denials. Payment included in another service received on that next bit of information, the question mark 001XX stands for what would be on that remittance advice a date. So payment is already included in another service that was received on such and such a date. So this is a bundled payment denial. In this case, you would have to check Medicare's guidelines to see, is there a modifier that you can add to unbundle the services? In some cases there is, and of course it would depend on the documentation you have. In some cases it's not appropriate to receive separate payment. Next, procedure code submitted is a non-covered service. There is a situation where you would want to be looking at the procedure code you're submitting and looking at CMS's relative value file to see if it's a service that can be covered by Medicare or a non-covered service. And what you're going to want to look at there is the status code column on that relative value file, or you'd want to make certain you do want to make certain that it's a valid code. Maybe it just simply wasn't entered correctly on the claim form, so it shows like it's a non-covered service. Those are things that you'd want to look at. The time limit for filing your claim has expired. No appeal right. This one I'm going to show you a resource right now, because this is one that kind of keeps happening, and we want to make certain providers know that the time limit for filing a claim when it expires is a situation where there is no appeal right. However, there are some situations when you can contact our claims manager and ask that that be waived. Now here I like to search versus navigate. I just put the word timely here, and here's a match, timely filing of claims. I'm just going to choose a Part B side since we're talking about Part B claims, accept the licensure agreement, and show you that on our website, and this is also included in the resource section of your presentation materials, we have timely filings of claims. This talks about the fact that a claim must be filed within 1 calendar year of the date of service. And specifically what I want to talk about is a couple of things. Claims that are denied for this reason don't have an appeal right. Denied claims not filed within the time limits due to a third-party error are typically not a reason that CMS accepts as an error that we can justify not submitting a timely claim to Medicare. That information is in the IOM publication 100-04. It's chapter 34. We link to it in this resource on our website, and this verbiage right here is what we use to tell you that CMS does not accept errors caused by incorrect third-party payment as justification for not submitting a claim timely. Now, there are some situations where we may extend that late filing limit. Those are addressed here. And then, of course, we include in our resource how to file a waiver to extend the timely filing unit. So I did want to point that out to you. I know that for the time period we're looking at here now, there was 20 denials for your specialty. It's just kind of a heavy hitter across the board, not just for osteopathic manipulative medicine. Expenses incurred prior to coverage or after coverage terminated. Whoop, excuse me, I went too quick with my scroll button here. 20 and 18 denials respectively. Check your date of service to make certain that you keyed it correctly for both of these situations, and check eligibility. Was there coverage for that beneficiary or that provider prior to the date of service you billed or after the date of service you billed, and so on. The next denial is denied service or units of service are exceeded. Show 510 there. I must have switched these denial reason slides around, and I apologize for that. This is a situation where you would look to the medically unlikely units or the Medicare unlikely edits, those MUEs that are published on CMS's website. These provide you, it's an edit table that provides you with the maximum units of service you can bill on the same day for the same patient, the same procedure. I will point out the resource for you later in this presentation. Separate payment not made for this service, do not bill the patient. 507 rejections. You can't separately bill for some items or services. If it's a situation where you can consider appending a modifier to a service. Some of these denials pertain to a local coverage determination. You can use the code lookup tool on our website. I'll show you where that is right now. You go to the WPS-GHA website. On the home page here on the left side is the code lookup tool. You can click this button to search an LCD article lookup by entering the code, the title, or the definition. Similarly, if you want to search for a national coverage determination, you can do the same thing. Just enter the code, title, or definition and hit search. That is the code lookup tool. We'll tell you if there is a coding and billing article associated with a local coverage determination or an LCD, local coverage determination, or national coverage determination. Next, claim must be sent to the employer group health plan, and the remittance advice code prints out just like this, so that's why it's listed with the acronym here on this slide, but it does stand for employer group health plan first. That means there is another insurance primary to Medicare. You need to submit that claim to them first. Next, provider number not valid for these Medicare services. Check that provider number, make sure it was keyed correctly. Make certain that that provider is one that's eligible to bill for those services that you're billing for. There are some restrictions as to who can do what in Medicare, so you'll need to make certain that only those providers that are eligible to bill for that item or service are submitting that claim to Medicare. It's going to be also another thing to consider here would be your state scope of practice. Does the state of Iowa, Kansas, Missouri, Nebraska, Michigan, Indiana allow that particular provider type to bill for those services? That's another consideration to think about. And next, can only pay one initial visit per specialty. That's type of one initial visit is allowed every 3 years for Medicare. Remember, same specialty, same clinic is considered same physician. And this is actually a specialty parameter that only one initial visit is allowed. Now let's go on and take a look at the codes here that are commonly denied, and for those reasons that I just talked about. Most of these commonly denied codes are OMT, or Evaluation and Management, or E&M codes. You know that OMT is a distinct manual procedure employed by physicians. It aims to optimize a patient's health and function. OMT encompasses a wide variety of techniques, and it is only appropriately provided by a DO or an MD that has been trained in OMT. So there you get that specialty designation there. Only certain types of providers can render certain services. So only DOs or MDs can provide the OMT. One of the, as you registered, you could identify something you wanted to learn about either today or in a future webinar, and I sent an email out to those of you who suggested things that we didn't advertise we were going to talk about today. And I told you that that survey that you're going to be asked to fill out allows you to, suggest those for future education. And of course, we also have a list that I place those topics on that I didn't advertise I was going to talk about today. But one of the things that came up on that list, and I saw a couple of times, and we've actually talked about it during other education that WPS has held, but that's determining when an E&M and an OMT is considered appropriate. CMS requires MACs to follow the Medicare National Correct Coding Initiative procedure to procedure, or PTP edits. And there is a current edit in place to deny evaluation and management codes when billed with osteopathic manipulative treatment codes, that 98925 through 98929. Now, this edit is indicated as following the CPT manual when you look at that information on CMS's website based on CPT manual. You can refer to guidance that's provided in the 2022 CPT book, and when modifier 25 may be appropriate to append to the E&M code. So what you need to remember is that when documenting, it's going to be important to understand how both services are connected, but why OMT should be separate from the E&M service. You can use Medicare's resources for more information on this. In addition, your professional association may provide coding and billing advice, whereas your MAC is prohibited from coding and billing advice. So there's some resources out there. The Modifier 25 fact sheet available on our website. CMS has a great article. You can just simply search the CMS website. The name of it is Reporting CPT Modifier 25. Also, CMS has their Evaluation and Management Services Guide, and that includes information about billing that 25 modifier. And I've included the link to that guide in the resources for today's webinar. So, different opportunities for education that already exists on using the E&M codes and OMT codes and modifier 25 with that E&M. One other code you're going to see here is the G0439. That's the annual wellness exam subsequent visit. And I did look at the top reasons for denial of this code. The first is that it's a duplicate charge. The second is benefit maximum for time period. This is a code that pays only once in a 12-month period. So if you exceed that parameter, it's going to deny. And then the third most often reason for denial of this code is that the claim must be sent to the EGHP first. Another commonly denied code is the 97110, and the top 3 reasons for denial of it is also duplicate charge paid on another day on another claim. The next is the time limit for filing your claim is expired. And the next is that the provider is not valid for these services. So the provider performing the service is not allowed to bill the 97110. I mentioned to you a little bit earlier, there's a number of ways we can break down data. We can break down state by county, state by code, state by county by code even. Sometimes when we speak at partner events, we'll narrow rejections and denials down to the physical locality surrounding the city where we're at and talking with people. We also look at trending, and CMS expects us to do that. For osteopathic manipulative medicine, the claim count for claim denials 3 months prior to when I pulled data was 334, but the claim count for the current 3 months of data was 828. So you can see there was a spike in claim denials. So then we need to analyze data to see why. Here's a breakdown of a specific denial example. Timeline or time limit for filing your claim is expired, no appeal right. In the current 3 months, there was 20 denials. The 3 months prior, there was only 3, so the difference in the number of claims is 174. So this particular denial jumped in 3 months by 567%. So the difference in claims, of course, was an increase. And these are reports that we can easily access just in a few seconds. Here are those resources and tools then that I promised to deliver during this presentation today. It's part of the advertisement. I said I would cover the resources and tools. These are the requirements for Medicare claim forms. Remember, if your claim is rejected because something's missing, I would look here to the Medicare Claims Processing Manual. Specifically in Chapter 26, you're going to find uh, item by item on a paper claim form what you need to include on your claim. We have available this 1500 ANSI 837 5010 crosswalk, and this is something I like to share with audiences because people don't know it exists. If you go to our website, on the home page you will find click links listed on the right. EDI, or electronic data interchange, is listed here. If you choose EDI, you will actually go to our EDI website. They have a separate website than GHA does. Scroll down and you will find Medicare EDI. Choose it, and you will then find the Medicare EDI webpage for WPS providers. Those companion guides I talked about earlier, the 277, 276 companion guides, are here. These provide those data elements that are required on your electronic claim. Here's that crosswalk that I wanted to show you, and this is just simply a I'm trying to get it to go here, but it's a little finicky today. This is, let me make it a little bigger. The crosswalk that shows you item by item on a paper claim, and that's this first column, item number. These are all items on a claim form, the CMS 15 claim form. Not making it move. And then where you need to put that same information if you're submitting an electronic claim. It'll give you the data element description, requirements for the electronic claim, the loop where it goes, and then provides for you the segments of the claim that you need to populate to provide that information. Item 19 is used for a number of things, so you can look at those requirements here. What is it you're reporting? Here is the status column that says whether an item on the claim is required or situational. You'll see several S's here. Here's an R on this page. Looking down here, more S's, more R's, more R's. If you look to the bottom of each page of the crosswalk, you will see required means a data element that's required in order to process your claim. Remember, claim rejected because something's missing. This is going to be your tool. S means that the data element must be completed if other conditions exist. So this is a great tool to make certain you're reporting all of the required information on a claim. Okay. How to correct a rejected claim appears on our website. We list by remark codes the most common reasons for rejection and how to fix them. Similar to what I went through quickly for those top rejected reasons for specialty 12 providers. Similarly, we have common claim denials. These are by category, but still listed by those reason and remark codes that appear on the remittance advice. We have bundling, global surgery, entitlement, provider number denials. So by category, look for those reason and remark codes and it will provide help for you. Here are other resources, our website. Here are MSP questions and answers. This is where you will find on the Encore Presentations webpage recordings of previous education. I showed you the LCD and article lookup tool that appears on our homepage of our website. Here's the link. Here's the link to our YouTube channel. Provides many different playlists and such that would apply some of those topics for specialty 12 providers. Modifiers web pages where you'll find a listing of all those modifiers that include appropriate use of this modifier, not appropriate use of this modifier. If some of you are interested in learning about rejections and denials specific to your billing entity, there is a process you can use. It's called Freedom of Information Act to request that information. However, there may be a charge associated with it. We want to partner with you is included here. Because those of you that belong to professional organizations may have opportunities to invite a speaker to come and talk about rejections and denials or anything else you want us to talk about. But this will take you to the page on our website that tells you how you can do that. Place of service codes for professional claims. We had some, I don't know if they were rejections or denials, something I talked about earlier, that you can't use this CPT code with this place of service. This is that procedure code listing for professional claims. The Medicare coverage database and how to use it is on the CMS website. The MCD is a national searchable depository of national and local coverage determinations. These are what define medical necessity. So there may be reason for you to look to see if there's policy for a particular item or service you're billing. You can find that in the MCD, and then this great tool tells you how to use that. Evaluation and Management Services Guide. I mentioned to you that there's a little bit of information in there about using a modifier 25 with an E&M code, so I've included that link for you. Medicare wellness visits. Remember that G0439 was one of the top rejections or denials, so I've included the MLN, which is the Medicare Learning Network educational tool for that particular item or service. More website resources. Those procedure to procedure coding edits that I talked about earlier, reasons for either rejections or denial, included out on the National Correct Coding Initiative edits website. This will include links to them. It also includes a link to a helpful how to use this file or these edits document that CMS makes available. The Physician Fee Schedule Relative Value Files is the CMS file that provides that status code that tells you if a particular CPT code or HCPCS code on that file is valid or not valid for Medicare purposes. Is it an active code or is it not valid for Medicare? So this would be to avoid those denials for services that are not covered. Dataset for ordering and referring is a CMS file that lists for you all of the eligible providers who can order or refer Medicare services. It identifies those providers and includes the identifiers that you need to place on the claim. I know some of those, I believe, rejections that we talked about today was because that information was either invalid or missing. CMS has published Checking Medicare Eligibility, which will help you with tips to check Medicare eligibility. Was the provider eligible on a certain data service, or was the beneficiary eligible on a particular data service? It's an eligibility check. And then here is a link to the Black Lung program for those denials that are related to entitlement, because the Black Lung program needs to pay for that beneficiary's services versus having the claim submitted to Medicare. That's that United Mine Workers. Here is a couple of self-service tools that we have available. Both of them are used to check eligibility or find claim status and details, although the portal actually will provide you with a little bit more information than the IVR. These are available 24 hours a day, 7 days a week with limited functionality outside of normal business hours. For the IVR, you use your voice or telephone keypad, and if you don't know how to use it or you have questions on its functionalities, you can check out the IVR operating guide, which is available on our website. Similarly, here's the information about the portal. Same thing, check eligibility, claim status, claim details, and claim actions, but there's a little bit more information available here. When you're looking at claim details on the secure portal, there's a button that appears next to a denial or a claim line denial that will say more info. If you click on that button, and let's say the denial was due to let's say it was due to a policy. It didn't meet policy requirements. That button that says more info will bring up that policy or let you actually link directly to that policy right there from that particular page. So it's a great time saver and provides for you some of these great and lots of resources that we have available. Instructions are available in the portal user manual. When you are on the WPS GHA website, The portal user manual, there's a link to it on every single page. You'll find it either at the top of the page under the login button where you can log into the transactional portal, or in the big blue box at the bottom of each and every page of our website. This would be the time we have available for questions, and I'm sorry that we went a little bit long today, a lot of information to cover in these 60 minutes. So I'm going to ask you just to put those questions on hold and how you can submit them to me later following this webinar, and I apologize for running long with my remarks. I do need to tell you this on behalf of CMS, because CMS has asked us to do that. CMS and Noridian are teaming up to host an annual National Provider Enrollment Conference. It's the 28th and 29th of August this year in San Diego. Times for those presentations vary by day. A description, a schedule, and a means to register are available by using this link that is on this slide, and I've asked Leanne to place the link into the chat so that you can get more information on this. If you need to, please pass this on to any of those folks at your organization or entity that might want to attend this free conference, sponsored by CMS and Noridian. Of course, you'll be responsible for your transportation and lodging and food, but the conference itself is free. So this is a great opportunity to learn. Our greatest compliment is when you recommend our education to others. Please help us reach our goal to provide current and effective education for all those in our jurisdictions by recommending our education to others. On behalf of myself and Leanne and all of Provider Outreach and Education, I do want to thank you for your participation. We look forward to those survey comments, and we hope to have you join us for future events. You may now disconnect.